Now I've done this presentation twice. The first lot, there was lots of participation from people and it went really well. The second, less participation, not quite as good. So I encourage you to participate as much as you're comfortable to, and even more than that. And feel, okay. So the aim in giving the presentation is to get you to think how you think about difficult people. And from my perspective, if you learn one thing, then it's hopefully worthwhile coming out tonight. So the topic is conflict resolution. I'd like you to take a moment to actually rate yourself how good you think you are at resolving conflict. So when you get into an argument, if you do well most of the time, then you're a high 7 to 10, average 5 to 6, below average 4 to 0. So if you mentally score yourself now, we'll return to this at the end. And I'm going to get volunteers from the low and the high group to hopefully participate and tell me the way that you think and whether that predicts outcomes. So anyone, hands up those that rated themselves below average on conflict resolution. Oh, Joe, you're going to be so popular. Fantastic. So everyone else is average and above? Okay, good. Well, we'll see what you think towards the end. So the rules for the presentation: ask any questions at any time you like, and I'll address them there and then. I encourage you to participate, and I'll answer the questions when you ask them rather than saying I'll cover it later, because I find it frustrating if I come along to a talk, I ask something, they say they'll get back to it and they don't. So in terms of Therapeutic Alliance, so my job is working with patients. The way that you keep people on board is working on what they're interested in focusing on. So rather than what interests me, we'll focus on what interests you. I also brought all the books along that I've sort of referred to, and just as an aside, I've got a good book on neuroplasticity and pain syndromes, which is relevant for dentistry, just in case anyone's interested in that. So, and Lee did the pictures, as I said. So an overseas study done in America found that a quarter of the people polled had what was considered high dental fear, and amongst that, 3.7% had a dental phobia. So in terms of phobia, that predicts avoidance behaviours and significant estimation of how awful treatment will be. And so I'll return to this point. Now, in the Australian sample, the prevalence of high fear was lower, but still 16%. More females reported fear than males. And the highest fear was in adults 40 to 64. And adults aged 80 had the least high fear, which I found interesting. You would have thought they would have been traumatised by early dental jokes. Okay, dangerous.
Nature.
That's right. Nice. So the things that predicted dental phobia were sort of interesting in part. So the highest rated thing associated with dental fear and phobia was the cost of dental treatment. Did anyone else find that bizarre? Yeah. So not pain, not anything else, just how much it was going to cost. We'll come back to this and how this might affect patients' responses to dentists and treatment. So there's an implicit assumption in me detailing these facts about difficult people. What's the implicit assumption about who's difficult?
This patient.
Yes. And is it always the patient that you have most difficulty in dealing with at your work setting? partners, anyone else? Anything else?
Parents.
Parents of patients? And what about colleagues? Interestingly, when I gave the presentation to the receptionists and the nurses, they actually rated the dentists as more difficult most of the time than the patients. So, Now, Dale Carnegie wrote a book called How to Influence and Influence People, and it was written in 1936. Now, the interesting thing about this book, he did a review and looked at people who were successful in dealing with people. And even now, I still recommend this book to patients because it's effective. One of the things he argued is it's possible to change other people's behaviour by changing how you behave towards them. So what does this mean to you, given that you're dealing with a quarter of the people to 20% of the people with high dental fear? Implications? Alex?
Well, you have to assume that they're frightened. You're dealing with 1 in 4 people who are fearful, and so you have to expect them to be fearful and not confident when they walk in.
And the second part, that you can change how people will behave dependent on how you behave towards them.
Yeah.
Totally.
Yeah, I agree.
Okay, so
Just reading.
further fact for consideration, when we experience emotions, we feel it in our body. So if you were feeling anxious, tell me some of the symptoms you might notice.
Nail biting.
Okay, you might observe nail biting, and if you were anxious yourself, what would you feel? And what would you notice in your body?
Just high level of arousal, feeling really stressed.
Sweating. Anyone get butterflies in their stomach?
Flush face.
Yep.
Tight in the chest.
Yeah.
So,
Right. So all this feedback comes into the body via the right side of the brain. Right side of the brain is non-verbal. So a patient is highly aroused and there isn't words attached to it. Right side of the brain is also responsible for the other negative emotions. So you're primed to feel anxiety, disgust, fear. So the fact that a quarter of your patients have high fear and 3% have dentophobia means they're coming in with negative emotions primed. Why does it matter? It's Leah's picture. Okay. A study by Davidson and Beckley found the simple act of describing distress decreased arousal. Anyone want to hazard a guess why?
Because you're verbalising.
Yep. So if you put emotion into words, it has to cross the corpus callosum into the left side. Left side of the brain primes positive emotion. So even if people actually describe what they're feeling in words in their head, they'll immediately feel better. So this is a strategy for patients in dealing with arousal. So instructing them to think about it in words is helpful. Okay, so why does it, when you wake up in the morning and you have low mood, tell me some of the typical thoughts you might have.
Stay in bed.
Yeah, stay in bed. Other ones? Sorry. Shame yourself-employed. Yeah, so there's a mood-dependent bias in thinking. Mood depends how we think, what we notice, and how we interpret what we see. So happy mood, rose-coloured glasses; negative mood, less favourable coloured glasses. Now, what that means is if there's something ambiguous going on, that is, the patient can't work out whether it's positive or negative, if they are anxious, they'll put a negative spin on it. So if you say something that can be interpreted either way. When they're anxious, it's tipped to a negative interpretation. So what influence would this have, do you think? So in the face of ambiguity, it becomes a negative interpretation. What does it mean? Come on, you like group number 2. What's it mean?
And more anxious.
Yeah, but also if you say something like, give me some examples of an unclear statement that could be misinterpreted.
Could it be something like you tell the patient, oh, you're going to require a filling, instantly they think, that's going to cost me this much money, it's going to be painful, we're going to have to come back, and that's that negative tipping. Whereas a filling is going to actually help them, make them feel better, give them less pain, and be better for their health.
Absolutely, and also depending on their history with people, if they already have a negative view of dentists, they can think things like, dentists must need to send the kids to a private school, I wonder if I need the filling. So there's a negative bias in how they think about what you're saying. Now, this literature is stuff from the marriage literature. Why is it relevant? Because even though you're in a professional relationship with your patients, it's still a human relationship. Now, Professor Howard Markman found that you can predict, no, he used to be a Hollywood. So you can predict with 90% accuracy who will get divorced after watching a couple interact for 15 minutes. Now, we'll come back to this. You can also predict with 90% accuracy, same guy said, Howard Markman, how well the conversation is going to go based on how it's started. So if a patient comes in and they snap at you and you're not being mindful, how are you likely to respond?
You don't like to shut it.
Probably mirror what they do.
Good example, Alex. So if a patient snaps and you're not mindful of your own communication, it's highly likely that you'll snap back. Now, once you start on that negative spiral, it's quite hard to turn it around. Not impossible, but difficult. Now, the problematic relationship patterns that they've found in marriage, they can be generalised to any human communication. Now, there's patterns that predict failure in all types of relationships. So, escalation, the part about this is escalation requires two parties. So if one person says something negative and the other person responds in kind, then it cycles up and goes very badly. Invalidation is any statement that you infer that what a person is feeling or saying or doing is unreasonable, unwarranted, not understandable. Negative interpretation.
Give us an example of invalidation.
Tell me how you're feeling.
Comfortable.
You shouldn't be comfortable, you should be uncomfortable, you're in the spotlight. So it's basically saying that what you're feeling or saying or doing is incorrect, not understandable. So when you define a difficult person, I find it really interesting because I've definitely got a bias in the type of person that I find difficult. What sort of person comes to mind? So,
Chronic pain.
oh, and what about, so how does a person present with chronic pain?
Very important.
So usually they come in with negative mind straight away. They've usually been to a few practitioners. They don't think they're going to get better. They think it's a waste of time, getting forced to come. They've had the pain for years, so have all that central sensitisation, and you know it's going to be a nightmare and take a lot more effort.
Okay, so someone that's been in pain for a long time, got a negative mindset, not open to how treatment will go. Anyone got a different view on what they consider a negative person or a difficult person? Ashley?
A patient who doesn't take responsibility for their own problems, that kind of projects it onto your dentist, it's your fault, they have a whole,
Right.
or it's the previous dentist and things like that, they don't kind of own their own health.
Actually, Ashley raises an interesting point. In doing therapy with patients, I always ask if they've seen another therapist, because some have, some haven't. If they have, I always ask them how the relationship went. Why do you think that is?
So they can tell you the rights and wrongs, and they tell you the wrong, you just don't do it. That makes it simple.
Exactly. So what they say about the other dentist is highly likely they'll be saying it about you shortly.
Yeah.
So it gives you an idea of what they don't like and their attributions of blame, is sort of suggested by Ashley. Anyone got any other type of person that they don't like dealing with? Student?
Someone who comes in and they sort of tell you exactly what they want, they're not really open to listening to like what you think.
Oh, okay, so they've made up their mind. Oh, see, I'd be one of those annoying patients who definitely would know what I want.
Well, there are people who want to be in control. They just want service delivered based on their own self-diagnosis.
Right. And that sort of places you in quite a difficult situation. So no one said really aggressive people or really passive people. No? So when we're teaching social skills to patients, we always encourage them to recognise that there's 50-50 responsibility. So if you're giving it your best shot and you're getting nothing back, you most of the time can't do more than that. Now, should this 50-50 split on how a interaction go apply in a clinical setting? Because who's on the back foot? Sorry? Yes. So, as a professional, whether you like it or not, you are more responsible and in control of how the interaction will go. Basically, you have to try harder to keep people on board, because, and we'll come to why. So, why bother establishing a good working relationship with the patient? There are multiple, but the risk of being sued, as suggested, outlined by Alex, has got very little to do with how many mistakes a practitioner makes. So both highly skilled doctors, physicians, dentists have complaints made about them and get sued. And there are doctors who are less than average and they don't get sued. So it's not the standard of care that results in someone being sued, it's the relationship that you have with the patient. And they have found people do not sue doctors and dentists that they like. So there was an example in the book by Gladwell where a person had a brain tumour, wasn't diagnosed by their general practitioner, and the patient said, no, I love my GP, it was that stupid radiographer and radiologist. So even when they had a terminal illness, they still weren't going to sue this doctor that they liked. So it's a powerful influence on outcomes.